Good morning, everybody. As every morning, we start positive, but the technology start tricking us up a little bit. We broadcasting from Mexico City, and then we connected all over the world. I want to say thank you to Alfredo Bautista, by the way, that he's been helping us to make this event going on. And you guys don't figure how many technicalities and process has to be done. It looks like a small operation, and it's small because technically we're doing it ourselves, but it's a lot of work. So I'm really happy that people is enjoy it. I appreciate all the positive messages that I receive. People encourage what we're doing, how they enjoying the information and everything. We just want that you guys help us to spread more of this information. The objective that we have with this, as we say from the beginning, is to try to put some different points of view and information that to me is relevant. Is people that I met them and inspire me. I have the chance to see them lecture or know them personally, and I know that they have many things with us in common, and it's many things that I definitely is material that I consider really important for everybody to see, whoever is taking care about the physiology of occlusion. Today is going to be a fantastic day. We say that every day because it's fantastic. I think the selection of the friends that give us a hand into this project, they're magnificent physicians, and everybody has a common denominator to start thinking in physiology. We all have different ways to do it, but we
That's
will
right.
here most to find out and to share what we have in common. That this is the beauty of this meeting. We're trying to find out how many things in common because we believe that in some point occlusion can become more attractive, more universal, and everybody can start seeing this with different eyes. So without taking longer, I want to introduce for my friend for Poland, Lukasz Lassmann. I call him the kid in dentistry, honestly, because he has to have the beard, so he looks a little older, but he's really,
I
really a
know.
young man. And
I know.
the things that he does is fantastic, and he will tell us a little bit about the story. But I am going to take more time. So Hamid, can you introduce him?
Yeah, that's right. As you said, the day is going to be a great one. We're going to have Lukasz Lassmann with us. And one of the intriguing things about Lukasz, when I first saw, is that how young he is, as you were mentioning, and how early in his career he was able to critically think and figure out that there's more to it than just the clack clack, tap your teeth or put the articulator on, and went into different directions and figured out all these different factors that affect the actual dynamics of chewing and what we call occlusion. So, Lukasz, please give us like a little short mini bio background about how you got to where you are now.
Bio background. Hello, everyone. So I always have to explain about my age because everywhere I go, I'm always the youngest one, and it's like I know that I look even younger than I am. I am 31, and for the women it may be the compliment, but for the young doctor it's not. So you can imagine it's not funny when the patient is asking you, "Where is the dentist? Or is your mom here?" And at the beginning it was tough, so I needed to have I need the hair on my face to have the authority. And when I finally made my clinic 3 years ago, and then I was a boss, and the patient was talking to me, asking where the boss is, and then I was saying, "This me." It was like, "Oh, really? You kidding?"
No, look at this one over here behind me.
I know, it
That's
looks
how
like a
he
teen.
was figured out. Yes. My God.
I always had this problem. Now it's much better because when I started, I had completely no idea about occlusion, and I was pretty lucky to start in the office when I had an opportunity to do everything. So the first day after my internship, my boss asked me, "Do you want to prep?" I say, "Yeah, I want to prep." So he said, "Go ahead, you got 2 hours." But it was both arches. I mean, 28 units. And I was like,
Oh, wow.
2 hours? Last time I was doing one crown, I was doing it for 2 hours. So now I'm supposed to do it in 2 hours. But, I did it. and maybe not two, maybe three. But I was very pleased with myself. But at the end of the visit, my dental technician came to the office with a Facebook, and he asked me where are the segmental bite records. And I asked him what are segmental bite records, what is it? And he asked me how am I supposed to mount it in articulary right now? All the teeth are prepped, and I was so scared, you
Oh, I
know.
forgot the bite.
I forgot about because I didn't even know that's important. I thought that he'll after preparation he'll just close, I'll register, and that's all. And the funny thing is that when I finally delivered the crown, it was pretty nice. I was equilibrating a little bit, and this guy was not speaking English. He was Norwegian. I was not speaking Norwegian, so the communication was pretty tough. But he left the office. He felt fine, but he was coming back for equilibration, I think 5 times. And on the visit number 5, I finally, I contacted with my business partner. He was speaking Norwegian. So we had a translator. And the patient told me that actually he's got a problem to bite his fingernails, and not even a right hand, but the left hand, because he had a 5 millimeter thickness of the fingernails. So, this was because so I didn't even ask the patient what the problem is. So I was just grinding the teeth down, making them flat until it was okay. But what I'm trying to say is that I was doing many crowns, like hundreds a month. I was sometimes doing like 100 up to 200 units a month with no idea about occlusion. And from the time perspective, I think it was not a bad job. And I was thinking recently why. Because I wasn't increasing vertical occlusal dimension. So I was doing everything in a MIP. And because the majority of these people were over 60, so the teeth were distracted. So I was prepping all the teeth for the crowns. So there was no need to increase the space for the porcelain, and everything was in full zirconia. You can now imagine if you do not increase VOD, then you do not have a problem with position of the condyle. We just repeat the same acceptable position. If you have full zirconia, you do not have chipping on zirconia, but probably the periodontium will be overloaded if there's any adaptation. So I think this is a recipe for the success if you want to do it fast. But then I realized that, the daughter test, right? And all the people are saying the daughter test because you also have daughters, because the young daughters.
Treat it like you will treat your daughter.
Oh,
Is that one the one?
So the question is, would you do it to your daughter? And the answer is, of course, you will not prep all the teeth for crowns for your daughter. So then I started to increase vertical occlusal dimension to create a space to do the adhesive dentistry. And then all the problems started. Because I didn't even know what a deprogrammation is, what is a leaf gauge, what is a deprogrammer, what is a splint. So I needed to invest a lot of time and a lot of money for these courses to travel around the world.
Education.
And sure. Start with the course center and many other centers.
So when I met you in Poland, we barely talked in the phone, so I didn't know what to expect or what you were doing. And something that really catch my attention was that we found a really similar ground, because you would have all the foundation. Dr. Roccabaro has been going often to Poland, and he has current programs going there. So it's a huge influence of Dr. Roccabaro in that side in Europe. So when I saw your lecture, I saw how you even implement physical therapists in your own clinic full time, and they participate in the consult during the patients, and you make a really nice workflow where you guys collect the records and get the information. You get your opinion, but also with all these records, they go to the room with the physical therapy. So when the patient is leaving the office, technically is having an entire interdisciplinary idea how the patient what's going on. So it's a perfect communication. Your physical therapy is super engaged with you guys. That was impressed me a lot. It's one person during the team, because it's a full time, And I can see how you guys can take the huge advantage of that, because any procedure, any part of the protocol, you have the opportunity to have the neck treatment before you take a bite or during the adjustments that you do it. And I think that's a luxury that in the United States is a little difficult. In other countries, also South America. But thank God you were able to establish that. Tell us about a little bit about how you find out about Dr. Rocabaro, and how do you decide to implement a specific workflow into this, and then how you transition it to the occlusion registrations based in Dr. Coy's thinking process.
You know, a couple of years ago, one of my friends told me that I need to find, in occlusion, I need to find one God, because all the philosophies, they are so much different, and they are sometimes completely opposite. And then he told me that once you listen to John Coyce, then you listen to Pete Dawson, you may get confused. But the thing is that once you find your own God, you have to obey dogmas. And once you obey dogmas, you are not asking questions. So then I started thinking, oh my God, maybe I'll just waste my life on trying to connect all these philosophies to do exactly what you're doing now, trying to find something in common, try to find the differences, because it is unbelievable that people with such a different approach, they can all have the success, right? And some people are doing it in a very simple way, like Francesca was doing. That was amazing. I love to listen to her. She's got very nice temperament. The desert island. What can you do on a desert island? You will also have success. And what you can do with all these toys, you will also have success. Some people are not even, they don't even know what should be the proper occlusion, but they also have a success because of the adaptability of the patient as well. But then I started thinking, okay, maybe I'll check all these and I'll try to find something in common. So at first I came to a Coyce Center, and I'm very glad I did it, because when now
that was that was before Rocabaro training. So you went for occlusion training before Rocabaro?
I did some other trainings before Seattle. So when I came there, I've got some background, so I was able to ask questions. And so I mean, the first big international foreign course, it was Seattle. And then I decided I want to go deeper, but I was very glad I did it with John, because what I really like with this, let's say American occlusion, is that they simplify everything. No matter if this is John Coyce or Frank Spear, I love it so much. And this is a very good background if you want to combine it with this all holistic approach. Because if you start doing, let's say, gnathology, and you are a young doctor, and you have to do, you know, the gnathology for me is very complicated, because you have to calculate every single angulation of the cast, all this condylography, and then so on and so on. And when the young doctor, no matter where he lives in the world, when he is overloaded with this knowledge, and he just wanted to do the proper bite, and then you are speaking about cervical vertebrae, about sleep apnea, and all these things. It's, you know,
a little scary.
Because our students, it must be digestible. You know, it's like the goal is not to make him feel it's like, oh my God, it's so complicated. I feel even more stupid than before I came for the course. So I decided that I want to keep occlusion simple, because for me that occlusion is just the tip of the iceberg. All important things are underwater. And then if with these simple techniques, you can combine it with the sleep apnea, you can combine it with the posture, with the cervical vertebrae, and whatever you want to do. And I think Rocabado was a great choice, because everybody was speaking about Rocabado map of pain. I was like, what the hell is Rocabado? Everybody's speaking about him. So I searched for him. Then he came for 2 days lecture. He had 2 days lecture in Poland. He was speaking about all this stuff, but actually for these 2 days, there was no solution. So at the end of these 2 days, we were asked, okay, so what can we do with that? And I was like, oh, maybe I'll come back. And then he actually came back for 10 days. We had 10 days with Mariano. Wow. It was amazing experience, amazing. And I think it was at that time, I thought that this was my missing puzzle, because John is speaking not only about occlusion, and there's many, many dental fields, but occlusion is very simplified. He's not speaking too much about the TMD. So I also wanted to hear about TMD. This is why I decided to listen to Jeff Occlusion and many, many others. But nobody was actually speaking about posture, about cervical vertebrae. But many of these people, they do not speak about it because we do not have enough data about it. And there are many people that will not make the protocol with that unless we have a very strong evidence. And I think the
Yeah, but
problem
if
with
we don't start doing evidence, like we in a huge disadvantage in this contemporary physiology that we have right now, because the people with more reputation that I have huge respect for them, they always controversy that is not enough foundation in literature. And unfortunately, I think dentistry with the evolution of technology, that the technologies that we can use right now, jaw trackers that you can see internally the joints, machines that they program the muscles in one way, can be 100% believed for some people, but it happens. But use a simple test that Francesca does with cotton rolls, making the people walk, or another techniques and to take bite registrations like cranial bites, swallow bites, phonetic bites, everything that is something that is not just putting your hands in the patient's mouth. That is what we consider physiologic, because we don't have a muscle to replace nobody's hands in our mouth. So can you give us a little bit about the insight, or what is the theory, or what is the technique that Dr. Coyce used to take the bite registrations? Yesterday we had the opportunity to see Cyril, and he tell us a little bit about the way that he adopt the utilization of the Coyce programmer in combination with neuromuscular dentistry. Can you tell us a little more deeper, since you were currently fully trained into the Dr. Coyce programs? What is the philosophy behind, and which things we have in common? That people can have a perception and then they say, oh, yeah, this is in common. We think the same.
So when I listened to you guys about the chewing, I think this is something that you also have in common with John, because he's not speaking about guidance, because nobody's guiding the jaw while chewing, right? So anterior guidance and canine guidance is let's say parafunctional movements. So when somebody is doing it at night or during the day with awake bruxism, this is not the normal function. Try to ask the patient to go to the canine, and then they don't even know how to do that. They don't not believe you that they do that until you show them the mirror that it's like a puzzles, the canine to canine. So they must be doing it, but not while chewing. So what John's philosophy is that you shouldn't be taking care about anterior guidance unless you got enough space for chewing, because we very often we want to have a very nice guidance and then the patient is eating and banging on the teeth. So anterior guidance and the canine guidance is not a mistake, but this is an additional value as long as you got a proper space for chewing. There are some, sometimes it may be a mistake when you do the canine guidance, because once you got a periodontal disease, you don't want to overload the canine, right? When you got implant on the canine position, you don't want to overload it. When you got the TMD, you don't want to have anterior canine guidance not to overload the TMD, because we all know that they designed also, and they were also focused with the anterior canine guidance because it's relaxing the muscles.
So
But
you guys working more in envelope of function?
Sorry?
So the concept is more guide for envelope of function?
Yeah, the
Not for
envelope.
An envelope that has freedom of movement. You don't necessarily want that movement to be influenced with the anteriors. Only if the patient goes to the extreme of the corners of this envelope is when it comes into contact with the anterior.
Yeah, true. So it's like legal. So we are not too much focused on the articulator, because in some philosophies we are trying to copy what we have in our joint to put it into the articulator to make the perfect bite in the articulator, but we forget about it, that we forget that the best articulator in the world is actually temporomandibular joint. So what the problem is that I see what people are doing with this perfect wax up, the occlusal compass and so on, is we forget that we got the mobility on the teeth and the mouth. Models in the articulator do not have this mobility. The jaw is not the rigid material. Once it's just enough that you open the mouth too much when you register the bite, and then the teeth are in the wrong position because of the flexure of the mandible. Also, what we do not have in the articulator is we do not have that proper chewing which we have in our patient, and also not any articulator in the world will speak to you because articulator doesn't speak, right? And phonetics is a very important thing. So it's very often it ends up that you are doing this beautiful wax ups. You place it in the mouth and you have to grind it anyway because this is how we function with our TMJ, not with the anterior and canine guidance. So this is what I'm doing, actually placing temporis in the mouth, equilibrating them, and then copy paste into the Postural.
Okay.
So how you correlate the information that you get from the kind of cervical analysis of Dr. Rocavaro with the way that you guys take the bite registration? What is that? What is the main consideration, for instance, to design the programmer? How you can
more important question: at what point do you start with the craniocervical work, or do you start with the dental work and then treat the craniocervical issues? Please tell us the sequence.
It depends. It depends because you know you were talking a lot about instrumentation in some interviews. So I'll tell you that when the patient enters my office, my most important instrumentation is my eyes, because when my patient is coming inside, I look how he looks like, because if he's looking like this and he already had 10 different specialists in TMD, 20 different splints, and he still has an orofacial pain, maybe they're missing something, you know, maybe nobody even looked at the posture. So it is important. Also, it's important to look at the temperament of the patient. It's introverted, maybe depressive patient. Depressive patient very often has oversensitive nervous system, autonomic nervous system. So I first look at him, then I listen to him, because history is the most important thing at the beginning. And this is what John Coyce taught me. That he's got a very, very nice questionnaire. When you can ask proper questions, then you know when you have to go with some more detail. So once you know that patient, for example, has some problem with some orofacial pain, then for sure we do cephalometric picture. We will check the spaces between cervical vertebrae, because if there's compression and we increase the bite, we will induce even more compression. Because you know, we had a very nice case a couple of months ago when the patient had the programmer, and then he started having a headache, and then when he was riding the bicycle, he had even bigger headache. Because what happens on the bicycle? Posterior rotation of the head. Once you place a programmer, it's even bigger posterior rotation of the head. So once we start with the patient, it's like forward head posture, tense trapezius, and the posterior rotation of the head, and then we place something that causes even bigger posterior rotation, because it's not only the mandible is posterior rotating, it's also the head.
Sure. So that was my question, was coming in that sequence that I was asking before I started working about the protocols or the workflow. I was trying to see how he correlate those principles of action reaction of the cervical spine into the mandibular movement. Because my perception is with the deprogrammer, if that mandible doesn't have the chance to float and compensate also anterior-posterior position, all the increment that you create is creating pretty much a hinge that automatically create a posterior rotation. So that's why the question is how those concepts of Rocavaro can influence that part of the treatment, because personally that's how I find out that mandible in order to establish the craniocervical stability and let the cervical spine to be dominant into the system as a postural component that is prior to the jaw. It will rotate the skull and allow some movement into the forward, what sometimes create open bites and more space into the bite into the posteriors, because most people is expecting, and that's what we want to hear your opinion in the way that you guys work, is most people believe that just the anteriors open when you increase vertical dimension, but we have different components that can make that the patient has insufficient bite support, and when you get a bite registration, you can have a bigger gap into the back than into the front. What is your thinking process about that based in the action-reaction concept of Dr. Rocabado in reference with head movement and mandible reactions?
So once I know that I got the increased spaces between cervical vertebrae, for sure I cooperate with my physiotherapist. So we are doing the anterior rotation of the head, and we increase the functional spaces. And then we need the occlusal appliance that has only the contacts at the back. So we need the freedom in the front while we're doing this anterior crane.
So you do a pivot basically in the back to.
Yeah, I use a pivot a lot because I do a lot of distraction in the joint. This is actually like most of my treatment with TMD patients starts with a distraction, because once we got a distraction.
Correct. So that's another thing we have in common, because first you have to address the joint. So you're now talking about a very advanced, probably degenerative joint issue with completely distalized, and we always say first treat the joint. Once you get the joint done, then you can start with the teeth. So that's a great point.
Very often when we place the deprogrammer in the mouth, is not only that patient are cheating on us, but once they have like sleep apnea, they will go forward. And then you register the forward portion and you think, what the hell is going on? So what I'm sometimes doing to make sure that I register correct position is I'm doing the Dawson manipulation on the deprogrammer to check the difference between what patient is marking on the platform and what is the Dawson manipulation marking. So if the distance is huge, I do not trust it so much, so I send my patient back home for another 1 or 2 weeks. And if another 2 weeks, the patient is all tensed all the time, so and this point is not repeatable, sometimes I switch into the splint. Because what I've noticed sometimes is that I tell my patient to do tap, 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 and they do that, and I look at it, and there is something wrong. So I tell my patient, can you relax all your muscles? I know it sounds silly, tell your patient to relax. I know you'll use TENS to do that. And I'm telling my patient to relax. And then suddenly it was 100 times the same spot in here, and then it's 100 times the same spot in here. And then you get confused, because what we've been taught is that repeatability of the spot means that this patient is deprogrammed. And maybe
but that has multiple connotations, because you have a patient with anterior displacement of the disc without recapture. You have a small movements that you not identify the pattern of the vector of the jaw. You can gonna have repetitivity every time, just because just because mechanic the disc is anterior place, is no way that you can buy it in a different location. If you're gonna be, let's say that you have your disc anteriorly located, displaced in one side, this mandible is gonna chip continually, and it's just because the disc is anteriorly, is not even a chance to do recapture. And that's why many concepts of techniques to take bites try to go forward at the beginning to try to allow three-dimensional space into the fossa, because it's more chance to recapture. Now, the question for you is, do you treat only the joint that is having the issue, or you treat both joints? Because sometimes when you make that, and I know I've seen your videos, pretty much I know the answer, but I want that you tell them, because I know your protocols pretty well. And I see you doing vertical distractions into the patients, but and other people make distractions, making a stretching, and then that compromise also the joint that is healthy. How you make that management to be sure that you're trying to achieve the best congruency of the surfaces, and and allow the capability to recapture the disc and then have something to keep it stable.
Yeah, so I do most of the cases, I do bilateral pivots. Even 1 month ago, my brother made the mathematical formula for me, how high should be the pivots. And I'll tell you, don't do it more than 1.5 millimeter because it's pointless. So I'll pass it through to you, the mathematical
Awesome.
part of pivots. And I
Awesome.
also listened to Jeffrey Occlusion, and he said that pivots are senseless because the only muscle that could induce the fulcrum, the
Yeah,
lever, is behind. But you know, how can we forget about the external force? So we have to put a pressure on the chin, otherwise the condyle
of
will not.
course.
So
Like Rockabato teaches, yes.
very rarely use unilateral pivots, because once you use unilateral pivot and then you try to put the pressure on the angle, then you may overload this joint.
Distalize that joint. Yeah.
There were also studies that if you put a pressure in here, you're kind of distalizing the another joint. So it's better to use the muscles once you want to use the unilateral pivots. But I mostly use bilateral because also I'll not harm the healthy joint by inducing the destruction, by making the capsule more elastic and inducing gliding. It can be only better.
Yeah, but you don't think that that is going to induce also a deviation to the side? Because if you have two joints, they're restricted. They're restricted why? The disc is out. Now we have the disc out, and why that joint is compressed? Because the elevated muscles, actually, they lose the homeostasis. So now these muscles contract here more. Now we have no room here into the joint to let that disc get in. Why? Because the muscles are contracted. Now we have a good conditions in this joint. I don't say that we don't put bilateral pivots, but just explain the mechanics. So, or then we do another techniques. But then if you treat the two joints together, you're gonna try to gain in this one, that is the one that you space, to try to recapture the disc. But here, the joint also can have the same stimulation. The point is, eventually, when you're gonna take about registration, you're gonna take about registration that what you described to get to the same point is what we call to develop a trajectory, right? So that means that you develop in a trajectory, but now that side that is more elastic, it will be more loose. So eventually the midline is gonna shift um, simultaneously in both sides, and maybe if you have this joint that is collapsed, that the disc is out, that you already have reabsorption into the condyle, so you have lost substance into that condyle that is smaller, you're expecting that when you're going to take that bite, this gap here is bigger, and that's why we combine it with the question about infiltration of the growth factors, because we would say, okay, this is like when you have a wear, you put an onlay, here you gain the space, now you build the condyle. So
Look what happened when you finally reduce the disc. Once you get acute disc displacement without reduction, and you do it like with manual therapy on the same visit, like next day, the bite is pretty the same. But if the patient was going with this acute displacement for weeks or for months, occlusion will adapt to this. So what happened when you finally, with manual therapy, reduce the disc? You create an open bite. Right? So this is why we always have to have a prepared splint, or we do the immediate splint with the silicone to support this bite, because it's going to be extremely, extremely unstable. And this is what I was thinking about, these PRF and PRP and pumping the joint. Because once you pump the joint, the same happens. The condylar vertical dimension is increasing, right? So also you create open bite. So you must stabilize.
It happens.
No, but in our thinking, Lucas, we don't do that until we have the patient in a protective occlusion, meaning that unless we take the load off of that joint, it makes no sense to try to infuse these things to try to bring healing. You know, it's like I always tell my patients, you know, if I have a knife in my leg, it doesn't matter how much bandage I put around it. First, I have to take the knife out if I expect for that to get better. So if we agree that this occlusion or the poor bite that has caused that, you know, compression in the joint and the displacement, first we have to address that. And certainly with a lot of adhesion in the joint, we definitely agree that we need to start with some sort of pivot appliance or pivot bondings or whatever you're more comfortable with for a period. About how long do you keep them usually in that pivot?
up to 6 weeks, and I increase it gradually because I don't want to break these adhesions too fast, because that may induce bleeding and even bigger problems.
Do
So
you combine it with Dr. Rocabato's exercises, the side-to-side roll and forward roll? And
yeah, I mean 4-to-1 ratio and everything. Yeah, so lateral movements, yeah, everything, all of that. And also then when I do the splint therapy, I'm very lucky because my physiotherapist is, we got a physiotherapy office in my clinic. So when we set an appointment, it's always like first physiotherapy, then the patient is walking from one office to my office, and then I equilibrate the splint. So this protocol is,
that's perfect.
it's pretty awesome.
Are you using flat splints, or which kind of splints you using? Upper and bottom, or bottom?
You mean upper or lower? Oh, this is what we have. This is a difference between us, because I know you want to have the splint
car,
and then you want to go in the garage, right? I do the upper splints, although I know they are less comfortable for the patient. And because what I'm doing is I want to equilibrate the splint. So when I have the splint in the upper jaw and the patient is doing tap, 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 tap. So what I'm using is tripod with the condyles and the contact in the front. So then I'm equilibrating the front and to get the contact at the back, the same as we do with the platform. So I'm using this upper splint for the equilibration, because once I have it on the lower jaw, that would be the contact in the front. So that could also like sliding. It's not the perpendicular.
Or maybe distal. You're afraid that would be a distalizing
kind of, yeah.
movement.
Not the perpendicular contact, not the real tripodization, like with gauge.
So your splint on the top, you have a flat surface. So
just a little guidance, like 15 degrees maybe, and not looking like this, because I do not want to have any, I don't want my patient to feel locked. So it could be somewhere here, just a little guidance. And
then doesn't have anatomy. No anatomy in the splint.
No anatomy. I just let my patient to have a freedom.
And the patient wear it 24/7? Is the patient chewing and eating with the splint, or how many hours, or what is the indication for the patient to wear the apply?
I'll tell you. For some of the people, it's what some people say it's even better if you do not use it 24 hours. Because then once you take it out for eating and you load the retrodiscal tissues, you may induce fibrotic process. So maybe you'll get the pseudodisc even faster. But once I heard a nice sentence, no orthopedic in the world will tell you once you got a broken ankle that you got a plaster for all the time except for running. So once you're running, they do not allow you to take the plaster out. So this is why in most of the cases, I'm telling my patient to wear it 24 hours, but I know that there is a huge discussion about it. Also with the bruxism, what the study says, it actually, you shouldn't be using it every day and every night, because your brain is adapting to it and then you start grinding again. So some study says that even a couple of times a week is better than using it every night. So I was even thinking about maybe it would be better to use one night Cois the programmer and another night the normal night guard, just to just to cheat on our brain, because our brain adapts too fast to.
Guys, now we're getting the last 15 minutes. Javi, we have to make a Olympic run at these questions with Lucas here. All right, Lucas, thank you so much for sharing with us your protocol. Again, as we expected, there is a lot more common grounds here than there are differences in the minutiae. Let's just start. You have answered this a little bit before. What is occlusion to you, and who were you influenced by? I think probably should know that.
As I said, for sure it's not a canine anatoringitis. I think it's just the tip of the iceberg. And I think we spend too much time on calculating the angles of the cusps. I do not say it's wrong, but once you make the occlusal compass and it looks beautifully, and your patient is a bruxer and has a sleep apnea, they will grind this beautiful anatomy anyway, so they will destroy. So we need to have a background for making this beautiful anatomy on the teeth. So what occlusion is for me, bilateral simultaneous equal contacts in MIP confirmed with shim 8 microns, and non-interferences with chewing and speaking, and no balancing contacts. So this is occlusion for me, just to keep it short.
That's perfect. Thank you. And your influences, obviously, we know Dr. Rockabato and Dr. Kois. Anybody else?
Like Occlusion and bruxism is Manfredini. So I've got many influencers. Actually, I listen to all of them.
Excellent. So let's go to question number 2. Which factors do you consider prior to stabilization?
Obviously, the patient must feel well with what you see. It's like a range of motion. It's a cervical vertebrae. You may see some X-ray, but I mostly, when I've got the osteoarthritis, then I do the CBCT, and after the splint therapy, I do it one more time to check if we have got osteoarthrosis. Because once we do not have the cortical bone, I do not consider it, fully successful treatment. So the patient is not adapted.
But you do, previously you mentioned you also look at parameters like sleep and posture. You monitor.
Sleep for sure, because I've got also, I cooperate with the ENT doctor, and once we do the protrusive splint, this is very nice cooperation, because I only get patient who's got problem with the larynx. Because this ENT doctor, he's putting the endoscope with, he's first sedating the patient with a propofol and putting the endoscope and trying to find where the real restriction is. And he's like pulling the jaw forward and checking if it's really helping. Because what is also funny, there are some studies that says that bruxism is connected with sleep apnea, and there are studies that says completely not. And the thing is that it is connected only when you select the patient with the obstruction restriction in here, because when a patient has a problem with nose, how can forward jaw movement could help? And I was speaking to one of the biggest authority in the world. Can we maybe do this study? So I will select the patients only with this restriction in here, and then we will check if there is connection between bruxism. He told me, calm down, we are just finishing the study and prepare for the nice bomb.
But I'm gonna tell you, it's a nice study for Dr. Arnett, because he's a maxillofacial surgeon, but he demonstrates how you can change airway just modifying the occlusal plane. Because airways is pretty much managed by superior medial constrictor pharyngeal muscles, and sometimes depends on the level. It's going to be an influence with the mandible position or no, as you said. If it's more superior, the attachment, definitely, if that attachment is not changed, it's not going to be increase of the airway there. That is something that maybe we can ask the maxillofacial surgeon that we have, that he is at the same school of Dr. Arnett, what is that procedure. But it's a really nice article. I don't have it out of my mind, but if I find it, I will share it, because I think this is something else that we have a lot to explore. Try to see how surgical mechanisms can help besides just by maxillary advancement to increase airway. So that's really good to find different alternatives.
Maxillary advancement to do it very precise screw, because there is a tendency to pull the jaw too much forward. This is what I also want to do with the cooperation with my ENT doctor, because we got this fork to register the bite. So many people do it in 3/4 of protrusive movement. I normally do half of the road. But what I want to do is to give this fork to my ENT doctor, so during his procedure with sedation, he will register how much should I protrude the jaw to unlock the airway. And maybe
I'm going to give you a trick.
Yeah.
Just try, because you understand Rockabato well. Ask the patient, just as you ask to relax the muscles, and look the patient to look at the floor, and just gain the space between the teeth. That is
in a neutral position.
In a neutral position. That mandible will go float forward only until the body allows them to without harm any structure, because we're using technically the same patient to decompress that joint and to gain that mandibular advancement. Then what I do is I ask the patient to look down. I try to put my pinky between so I can hold that that is about 4 or 5 millimeters, and then I put a little bite registration, and then I complete it. Try that, just as a comparison, just because you understand the Rocabato thing, you'll be amazed how it's going to be a good airway, but you don't going to put that condyle over the eminence. That is when all these patients come back with.
All right, guys. All right. Listen, we're getting close.
Okay, go.
All right. Which diagnostic information and records do you collect, Lucas?
Which diagnostic information? So as I said, oh, I've got it. I've got something that's called physio chart. And what we check is the range of motion. We check C2, C1. We check the posture. We check the cephalometrics and the MRI sometimes when we really need it. We check the malampati to know if there is a risk for the sleep apnea or not. Stop bank questionnaire. So once the patient is at risk with the stop bank and the malampati, then I send them back home to get the polygraphy. So it looks like a watch. And this patient is sleeping with this. So once we know that he's at risk, goes to my ENT doctor. We check the muscles, but not all the muscles, because I do not think that there is a real need to check the lateral pterygoid muscle inside the mouth, because it's almost always painful. So what can I do with this diagnostic data? So we check the masseter temporalis. We check the suboccipital muscles, trapezius, because you probably know that trapezius is the first muscle that responds to increasing vertical occlusal dimension. So if patient has a problem with trapezius, he will have even bigger problem. So Rocabato, map pain, and so on. So I kind of combined the diagnosis from the COIS questionnaire with what we can find with the manual examination and the postural examination. So this is how we ended up with this protocol that's kind of combine all.
Beautiful collection of data. Which instrumentations do you currently use to collect these? Aside from your manual examination, are you using a CBCT, MRIs? You said you mentioned cephalometrics.
Yeah, but as I told you, I mostly use my eye and my ear at the beginning. And I do not have too much toys in my office. I use CBCT sometimes to check if there is no osteoarthritis. I use MRI just to make sure if there is, let's say, this displacement without reduction, but in most of the cases, I wouldn't even have to do that, because I know what's the diagnosis and I don't know how would it influence my treatment. This is what I also think about. I don't know neuromuscular dentistry so much, but I'm always thinking, what is the validity of these data? What is the reliability of this data? And how can you use this data in your therapy? If your therapy would be different if you hadn't used this stethoscope, Doppler, EMG, because I know for me it's like all the time it may be different. Skin thickness makes the EMG record different. Gender, age, it may all be a little bit different.
Yeah, so, but what happens is differentiation many times. Like for instance, you can have a trapment of C1 vertebra and you can be collapsing the vagus nerve, what is going to give you exactly the same symptoms that a heart attack. And the only differential diagnostic is the pulse, right? So it's something that when you start getting into this arena, when you start making a full differential diagnostic with dysfunctional patients, it's just tools into the armamentarium, because it's not, sometimes it's not about, people say, but it's superficial muscles. I don't care. Even you can use your fingers to see if the muscle in one side contract equal to the other one. If one temporary contract equal, and then you can compare four muscles, and then you can see if it's stored. It's just like a count in something else, because again, if we were treating only or dealing with easy patients, maybe, you know.
Yeah, well, but I can understand his point. Obviously, he hasn't delved into it, and there are very detailed analysis and people who have years of data and have been able to analyze it and give essential.
Yeah, you know, you can do many things without this technology. There is an Axel Buhmann examination, so you know if there's this ligamentous click, if this is adhesion click, hypermobility. to make you more satisfied, I'm using Occlusion. So it's like electronic measurement. And you know why I use
Aqualizer.
No, no.
What is
Occlusion?
that?
Mouse. This is like a T-scan, but the difference is a
Yeah,
T-scan
yeah.
is 100 micron thickness. For me, it's too thick.
I see.
You know?
Yeah.
And the Occlusion is also cheaper, and it marks the color on the T. So this is what I really like, because still you have to know where you want to.
Correct.
Where
You
you want
still
to
have
find.
to.
But I think the difference is the time of the occlusion. You know, the little snake
Oh,
into the middle of the
yeah.
occlusal arc.
All right.
They have.
We do not have it, but this is about software, so I hope they will develop
Yeah.
it.
All right, guys. Let's go. I think your next question you have answered already, Lucas. Obviously, you have a PT inside your office, so you do approach this with an interdisciplinary treatment.
Yeah, I do.
Right.
Osteopath, ENT doctor, and physiotherapy, and not to say about multidisciplinary treatment in my clinic, because most of the patients are first like orthodontic, then prosthetic, and then like we combine it all.
Fantastic. Very quickly, if you, I think you have also probably partially answered this. If you wanted to give us a quick synopsis of your sequence of treatment, especially on those patients that you open up the vertical.
Oh, so if the patient is asymptomatic, let's say he's asymptomatic, then opening the vertical, it depends on why I want to open the vertical. If I want to get a space at the back, I want to get a space in the front with severe attrition. If there is severe attrition, edge-to-edge bite in the front, and once I want to open the bite to know how much I want to open, I will do DSD. Because actually I can determine the final VOD with the DSD, because I check the display of the incisal edge.
Mm-hmm.
This is what I was also explaining in my last webinar about VOD. So then I determine final VOD. I can do the cephalometric picture to check if I can even do that, because maybe aesthetics will be better, but maybe the function will be worse. So if it's getting worse, then I send this patient to the physiotherapist. And in most of the cases, I use a coach deprogrammer or leaf gauge. If I have a deep bite patient with second class, I will not use leaf gauge, because that will distalize the jaw. But study says that once you do not clench strongly, you will not distalize the jaw. So I got mixed feeling, but I think leaf gauge is not so bad. And what else? Because
What
I'm
else?
speaking.
All right, let's keep going. Do you, I think, again, do you consider facial aesthetic? Yeah, facial aesthetic.
Yeah, he started with DSD and
DSD.
TMD. In most of the cases, when I finally finish with TMD, then we go through ortho, then we go prosthetics. So I have to keep it in mind. So half of my patients and half of my patients are Puma rehab patients.
Excellent. Let's go back to the joint, and I know you said you don't put a lot of emphasis in there, but what is your feeling about the introduction of those healing factors or growth factors of PRGF and IPRF into the joint? What do you think about that?
I think it could enhance the treatment. I believe in adaptation. Therefore, I do not use it, because most of my patients get fine after our therapy. But I know the data, and I know that arthrosynthesis is really nice, and this sounds logic, because we want to get rid of all the byproducts. Once we get these byproducts, we can get a sticky joint, we can get adhesions and chondromalacia and so on. So it's good to rinse it out. And I know that when you do it with PRP, it's even better than if you do it with hyaluronic acid. So I think one day I will have a patient that will really need that. And I know that before I will inject it, I want to keep him stable, and I want the capsule to be elastic to be able to get this 2 milliliters of the PRP, because when the capsule is retracted and everything is...
So you're gonna love the protocols of Alejandro Martinez, because he combined arthrosynthesis with the injection, and he simultaneously made the degradation for the scar tissue and adhesion. So I'm really looking forward for that lecture, because it's great to see it for a surgeon that made over 500 surgeries into the joints, and he stopped doing them to move to this more natural approach. So
But you know what is funny? I know we are running out of time. The funny thing is that when you look at the data and you check the conservative treatment and non-conservative treatment, that they all have success between 70 to 85%, no matter what you do. But the final study was Sato from Japan, and it turned out that if you do nothing, you get 68% chance that the patient will get better in 1 year. So you know, like, we can do all this stuff.
You see, that's why sometimes you need to just feel at your heart inside, because always is going to be an article that is going to try to destroy your moral, you know.
Yeah, you know, people were trying to put the implants into the joint and they now resign, so disectomy is better. Have you seen the latest definition of centric relation from Journal of Prosthetic Dentistry? They did dissection of the disc from the definition. There is not even the disc in the definition of centric relation, because adapted centric posture is also fine, right?
My God.
So, we know this.
Oh my God, we have to learn more. Keep going. We need to finish.
All right. Let's go to question number 9. I think you have also expected that. So after your treatments, are you observing postural changes? Expected, non-expected, positive, negative? What are you seeing?
Yeah, so I see that, because once my patient comes from the physiotherapeutic office, then I grind the splint because the contact points are changing, and I see it all the time. And I think it's also important to make the patient stand, because once you work on the hip, it doesn't make a difference if your patient is just sitting. So John Coyce has a very nice protocol, P1, which is joint, P2, which is contact on the teeth, and P3, which is chewing. And I think P4, which is posture, would be really, really nice to check the difference on the contacts. So sometimes I see unexpected things, unexpected bad things happening when you increase VOD and posterior rotation of the jaw is restricting your airways. And then we have to deal with that, and we have to work on it a little bit more. So, you know, once you increase VOD, many things can happen, expected and unexpected. So I see it all the time. This is why I call therapists.
Next question goes to our initial talk. We talked about it. You said you had looked at it. What do you think about the future of education in occlusion? Do you think some of these ideas that you spoke about are going to find their way eventually into dental schools and into our formal occlusion education?
You know, I'm a little bit pessimistic if we are thinking about it, this holistic approach all over the world, because people want to be effective. And once you combine all these things, you are not that effective sometimes. You may have less of relapse, but people sometimes do not think in the long term. They want to have a nice result from Monday to Friday. So I believe that they want to have a cost-effective and fast procedure. So you will have people who will treat the patient in a holistic way, and you will have people who prefer to do the fast dentistry. And I just hope that people will take care a little bit less about the cusps and a little bit more about all human cell, all the body, because
pay a little bit more attention to the whole person.
Compass will not resist grinding when you have a bruxism because of dirt, because of some internal disease, because we already know that occlusion is not the reason for many problems that we thought in the past. Bruxism is not because of the occlusion, and many other things is not because of occlusion on the central.
Fantastic. And the last question, this is, I know you guys, we kind of discussed it online before. So thinking about the events happening in the jaw joint, complete. Please, in your mind, tell us, what do you think is happening? First, second, simultaneously? Is it rotation, translation? What is the ideal positioning for that condyle in your mind when you finish your case? And I think you told us about your ideal bite, simultaneous, bilateral, full seat, correct? So yeah. Tell us, in that position, when you get it and you're happy, what do you expect to see? Where do you expect to see that condyle to be?
I prefer this musculoskeletal stable position. So once I do the tripod, I want my muscles to position it in the anterior superior position.
Anterior superior.
And so I use muscle braced position rather than gravity assisted position, like with TENS, right? So this is my way, because with gravity assisted position, gravity must equal the resistance of soft tissues. So kind of the toe is floating, right?
Hang, but we pack the joint during that. I mean, remember, in the same neuromuscular arena is different little techniques that people use to take different bites.
Yeah,
Many
sure.
of the bites get adjusted. Just to clarify that how it works is most of the bite, the pack get close with the calibration because they start continue doing the calibration, so that joint gets sit. But also it's techniques that the bite can be cut and then induce swallowing patterns, so you're still getting the distance between the cervical spine, the hyoid, and the chin, and that will set up the bite to pack that joint against the eminence.
All right, but we're not gonna, you know, as much as we would like to answer that question, but we don't want to get into the nitty gritty of the differences. Again, let's focus on the common grounds.
Yeah. So the question was, where is my joint, right? Where's my condyle?
Correct. So now you got that joint into that anterior superior position, and the patient goes to open. What do you think is happening there? Is it, do you still believe that the first few millimeters? Yeah.
Oh, yeah. So we've been taught that there is rotation at the beginning. What I think that the rotation is, we have rotation when you got acute disc displacement without reduction. So then when the condyle is trapped, then there may be really rotation. And also once you push the jaw backward and you got ligamentous position, so the old definition of centric relation, then people were so happy about this retruded position because it was repeatable. Once you put the condyle on the ligament, there's going to be repeatability, but repeatability is not always the best option, right? Once we already
correct. So just to be on the record,
just to be on the differentiation between rotation and translation.
There is no separation in your mind. In the correct physiologic joint, you're saying that that is not happening. It's a simultaneous event.
I really doubt, but I will not tell you what is function and what is dysfunction, because some people will tell you if the joint condyle is going directly into the translation, this is maybe because of the contracture of the contraction of the lateral pterygoid muscle. But let's not go deeper into the lateral pterygoid muscle because this is the most controversial muscle.
Right. So let's just go to the basic. You said that, just so that I have it, we're just tabulating these things. I'm not trying to put you on the spot or anything, but in your view, the rotation can only happen in a pathologic joint.
Or retruded jaw.
Oh, it's a pathology, correct. Whether it's retruded or disc outside, those are all different pathologies. So am I correct to assume that?
Yeah, this is my thinking. Although I know people are doing the hinge axis, they consider it to be stable once you got rotation. It may be possible with well-functioning joint, but I really doubt. So now, Javier, you got instruments so you can prove if there is rotation.
No, I think we're pretty much on the same page in there. That based on what Javier has collected over the last 5 years, we've seen that it only, as you said, the rotation is only happening in a pathologic position of the condyle. And in the correct position, it's either always all translation or translation and rotation simultaneously. So,
or you can do it in the other way when you put the tongue on the palate and you tell your patient to open very slowly. Then I can imagine that the joint may be only.
I will do now. I get it honestly. I enthusiastic to do that. I will try next, and I will share that. Trajectories with the tongue.
What I want to try on your instrument the distraction with pivots. I want to.
I
have that. I will show you that. We talk more.
That is fantastic. And I want to invite our viewers to please post your answers, questions, or comments on this very interesting subject and discussion. we'd love to get back to it on our wrap up and see what you all have said. But Lukasz, thank you so much for spending time with us and
Sure.
unselfishly share with us all your really interesting experiences.
Thanks a lot. It was a big pleasure to be among these specialists that are on the list, I feel.
Thank you so much, brother. You're doing amazing. I really want to congratulate you because I know what it takes. You're doing, the people that doesn't know, Lukasz is doing a lot of webinars, and he has a really powerful social media with a lot of education that is good to see everything for different perspectives. I want to ask everybody kindly to give us support. We appreciate the support watching us, but we want to help to spread this more. It's such a big work what we put in here, a lot of investment in time. We're doing this by ourselves, and it's hard work. So we want to leave something for the world that is able to see all this beauty of how everybody is doing different and successful. And the only thing that we ask for you guys is help us to promote this, because if the world get to hear this more often, maybe they will open their eyes tiny, little by little. So today at 1 p.m., and thank you, Lukasz, again. We'll keep on in touch. Definitely, we have more to. So we're going to have today at 1 p.m. Dr. Rick Robles. Robles, and then we have him. I met him at the Arnett group, and what I think is really important for him to bring to the table is his content, his content about corticotomies. And he's been doing this procedure for many, many years in combination with Krial aligners. He is one of the most well-recognized Invisalign masters, and he combined amazing techniques for corticotomies. That is a subject that I try to share with people, but people think that is a little invasive. But I want that you guys get to see the benefits and how much this speed up the treatments. So it's really worth it just to see with an open mind and see the benefit during the treatments, because for all of us that we think in physiology, airway and the form of the arch and everything is important. Remember, many people these days, they don't want to be involved with braces. So I found fascinating what Rick shows me. I'd see him lecture like 2 or 3 times, and this is the material that we want to have here. So please tell your friends that they're orthodontics or something like that, or they do Invisalign. If they want to learn tricks and pearls about how to do more comprehensive treatments, utilizing corticotomies and all the tricks and trucs that he has behind the sleeve, come with us, and I will see you at 1 p.m.
Perfect.
Thank you.
Thank you again, Lukasz.
Thank you very much.
Have a wonderful day, night for you. Go and sleep.
Evening.
It's 4 o'clock, so it's just in the middle.
Oh, so is that time for the beer?
It is.
Cheers. It's 9 in the morning, but I need one. All right, guys.